So hi friends, today I thought of discussing the RGUHS question paper, that is the Internal Medicine paper 1, the 3 markers of this paper. So this is my 3 mark series that I have started. So if you wish to see more such content in my channel, please do consider subscribing. So let's go ahead without wasting time. So be open to learning, let's learn it right now itself. So the first question was the difference between define hypertensive emergency and hypertensive urgency. Okay, just you have to just definition. So just remember that E stands for emergency and E stands for end organ damage. So if there's emergency, there's an end organ damage. It's associated with acute target organ damage. Okay, so that's the key here. So hypertensive emergency, acute target organ damage, but in urgency there's without acute organ damage. So of course, if this is an emergency condition, you need immediate BP reduction with IV antihypertensives. Okay, this does not. Whereas acute hypertensive urgency, where there's no any acute target organ damage. So even you can use gradually, you can reduce the BP, but it does not require immediate IV therapy. Okay, so this is a table showing the differences. Again, the similar thing. This definition is all that is required. So let's go to the next 3 marker, that is the causes of chronic diarrhea. I just enumerate. So you can just remember with this mnemonic. So everything everything is the issue with the GIT. So here there could be malabsorptive, that is any celiac or topical sprue. Then inflammatory, it could be associated with IBD or Clostridium difficile. Secretory is cholera and VIPoma or carcinoid. Osmotic is lactose intolerance and sorbitol. And chronic infections is TB and CMV. This is meso-C. Okay, this is the causes for chronic diarrhea. You can remember it this way. Then coming to what is the adverse effects of SGLT2 inhibitors. Okay, so I remember it using the mechanism itself. So SGLT2 inhibitors are nothing but it inhibits the sodium glucose co-transporter that is there in the this one, the sodium glucose co-transporter that lies in the nephron. It inhibits that. As a result, it inhibits there's reduced glucose reabsorption and reduced sodium reabsorption that's happening within the tubules. And so there's increased glucose excretion in the urine. If there's increased glucose excretion in the urine, what has happened? There's genitourinary infection. And at the same time, there's reduced blood glucose. So if there's reduced genitourinary infections, because of increased glucose, there's increased chance of urinary infections. That could be manifest as UTI, or it could manifest as candidiasis. And if there's reduced blood glucose, it can suddenly manifest as euglycemic decay. Okay, so I try my best to remember it this way. Sodium and glucose, with respect to that, what are the adverse effects that could be seen? If there's reduced BP, so there's like reduced BP, there could be what? Hypotension. So from here, it's a 4 side effects you can aram se write from the, if you just remember the mechanism from here, right? So if you want, you can just stick to this, or if you want further, I have just told genitourinary, that's only genitourinary infection, UTI and candidiasis. Then ketoacidosis, euglycemic decay. Then with respect to sodium, there's reduced BP, right? So dehydration, hypotension, okay? Then renal effects, as this entire thing, this drug acts in the nephron, right? So there are chances of AKI as a whole. And then canagliflozin comes with a special, like 2 different things. There's bone fracture risk and lower limb amputation. Okay, remember that. Canagliflozin. Okay, so because the thing is SGLT2 inhibitors as a whole, there are a lot of areas that's reported. So that's why they have asked it under as a 3 marker area, like adverse effects of SGLT2. So remember to write these 2 as well. And then if you possibly, you can remember hyperkalemia and lipid profile changes because of mild increase in LDL. Any kind of mnemonic lover could remember this. You can take a screenshot here. So you can take a screenshot here. Okay. Yeah, good. So let's go to the next question, that is clinical features of beriberi. Okay. So here you can remember it like, just like dry beriberi, wet beriberi. Dry is the neurological. So as a whole, what is beriberi? It is because of vitamin B1, that is the thiamine deficiency. So dry beriberi, wet beriberi, infantile beriberi, and in chronic alcoholics, because alcohol interferes with thiamine absorption with the GIT. So Wernicke encephalopathy and Korsakoff syndrome is seen in chronic alcoholics. Okay, so if you write that, that's more than enough. Again, dry beriberi, we have what? We have like it affects the neurological. So where you can just correlate with this picture. So here the dry beriberi. So you can have the foot drop, then wrist drop, then you could have like loss of reflexes. Same thing they have written here. Okay, and there's a burning feet syndrome because of kind of numbness, a peripheral neuropathy. That's why it's called burning feet syndrome. It affects the peripheral nervous system. Then coming to what wet beriberi is all about, the cardiovascular manifestation. So it's a high output cardiac failure, right? So high output cardiac failure. This is dry beriberi is all about neurological manifestation, PNS. So here, if it high output cardiac failure, that will manifest as what? Tachycardia. And with manifest as tachycardia, edema. Sorry guys. Yeah. It manifests as tachycardia, edema, sorry. So tachycardia, edema, breathlessness. Okay, and infantile beriberi is seen in breastfed infants to thiamine deficient mothers. So here the children will be restless, convulsions, cyanosis, all this would be seen. Wernicke's encephalopathy and Korsakoff syndrome. This is seen in chronic alcoholics, mentioned that. And Wernicke's encephalopathy, there's a very famous mnemonic that's called Goa MP. Global confusion they'll have. Then they'll have come with ophthalmoplegia. As here I have read the ophthalmoplegia. Then they'll come with aphasia. So this is the patient with the this one, Wernicke's encephalopathy. You can see here, right? Yeah. And then M is memory loss, and P is stands for psychosis. So remember it this way, okay? So try to correlate with this picture. Wet beriberi, dry beriberi, you can see the patient with like dyspnea, orthopnea, then there's edema. You can see it there, no? So that's it. So Korsakoff's amnesia and confabulation is seen, okay? So let's go ahead with the next question. That is treatment of hepatic encephalopathy. So hepatic encephalopathy, again, it's a neuropsychiatric syndrome that is seen. And it is majorly because here ammonia becomes the villain here. So because of which what? And the other toxin that crosses the blood-brain barrier, because here the ammonia is the major villain, so you have to try to remove the ammonia, that is reducing the ammonia production absorption and enhancing its ammonia metabolism. So identifying and treating the precipitating factor is also an important key. That could either be because of GI bleeding, associated GI bleeding, that you have to treat the bleeding transfusion. Then infections, that's broad spectrum antibiotics, electrolyte imbalances, correcting them. Then just like, just remember one to three, some three things, and you can write there. Then majorly ammonia things, no? So here the ammonia could be like, because of reducing the ammonia production, that's either to lactulose, rifaximin, or probiotics. Okay, these are the three things. How do they act? The mechanism is given here. Okay. Okay, so that's how it is. So lactulose, it traps the ammonia in the colon. Rifaximin is a non-absorbable antibiotic, reducing the gut bacteria that produce the ammonia. And probiotics, it promotes the beneficial gut microbiota. Okay, so that is the adjuvant. It can be used in adjuvant. So lactulose, rifaximin, and probiotic. This has to be mentioned, these three drugs. Then with respect to the enhancing the ammonia metabolism, you use Lola, zinc supplementation, and branch chain amino acids. Okay, so all the just remember this the things, and these are the mechanism of action, how it increases. Lola increases the the urea cycle efficiency in the liver. Zinc helps in urea cycle function also, and also branch chain amino acids is for beneficial in chronic hepatic encephalopathy. Then coming to neurological manifestation or monitoring, you have to keep monitoring the neurologically. Okay. Sorry, my thing is gone. Yeah, just one sec. Yeah, neurological monitoring is important. And severe case, you have to ICU management is also the key. ICU management, okay, in severe cases. So neurological, what you do, you have to do the GCS assessment and avoid sedatives. So then next question, let's go to, that is the clinical features with respect to envenomation by Viperidae, vipers. That is basically, vipers are venomous snakes, as we know. It is because of Russell's viper, saw-scale viper, and yeah. So basically you can divide it as what? Local effects, systemic effects, and the next one is delayed complications. Under this local effects, we will see what? Pain, then ecchymosis and blistering, and necrosis and ulceration. Then with respect to hematological toxicity, we can have DIC, bleeding gums, hematuria, epistaxis. Remember 2 for each is enough. Prolonged clotting time, all this you can remember, no, hematological. So remember that way. Cardiovascular manifestations is what? Hypertension, shock, and pulmonary edema. Renal is AKI, hematuria, oliguria. And neurological, I think this we can write it. Even if we're not studying, we can write, because if we know, provide is a hemotoxic drug. So it's a hemotoxic toxin, okay? The poison. Delayed complication could be secondary infection, gangrene, and CKD. Okay, so this is done. So you can take a snapshot here. Yeah. So let's go to the complications. The next question, that is the question is, enumerate the complications of ST segment elevation seen in myocardial infarction. Okay, so here I just put it like a story format. So you can imagine a person with heart gets a big attack. Then it falls apart in several ways, like in different ways, like a broken heart. It can either heart beats abnormally, that is manifested as arrhythmias. Okay. Or the heart can fail, that is shock and heart failure. Then the heart tears apart, that's rupture. Then the heart gets inflamed, that's pericarditis. And the heart forms clot, that is thrombosis embolism. And the heart stretches out, is ventricular aneurysms. The heart gets another attack, is reinfarction. So this is how it is. So if you guys want to learn further, you can learn arrhythmias is VF, AF, all that. Heart shock and failure, cardiogenic shock, acute left heart failure. Rupture is like either through free wall rupture, septal wall, or septal rupture, papillary muscle rupture. So inflammation means pericarditis, early pericarditis, Dressler syndrome. Thrombosis like mural thrombus formation, and that causes clot in heart and can cause stroke or limb ischemia. Then the heart stretches out, there could be weak heart wall bulging out and percentage ST segment. So remember, like heart gets beats abnormally, heart fails, then heart tears apart, then heart gets inflamed, forms clots, then stretches out. Stretches out means it will manifest as ventricular aneurysms, and heart gets another attack is reinfarction. So remember like that, like try imagining this way and you can get this better. So let's go to the etiological classification of AF. So you can manage, there's a high potential of this coming as a 5 marker, just saying. So cardiac causes, and then we have non-cardiac causes and electrolyte abnormalities and drug induced. Cardiac again, hypertension, CAD, chronic artery disease. Then we have valvular heart pathologies and CHF. These the 4 if you remember is enough. Then non-cardiac is thyrotoxicosis, alcohol, OSA, obesity and metabolic syndrome. Then hypokalemia, reduced kalemia, reduced magnesium, hypomagnesemia, hyperthyroidism. Hypoxia manifests COPD and pulmonary embolism. Drug-induced AF is beta agonists like salbutamol and dobutamine. Theophylline and steroids are other drug-induced AF. This physiological mechanism which prevent GERD was the next question. That is, describe the physiological mechanisms that is seen. So this one diagram is more than enough to fetch his marks for exams. Okay, this much if you write. You don't have to write this. I'm sorry. So just write this one diagram. This is more than enough for this, and you can take a snapshot here. So so here we have what? We have the first thing, the very first important parameter is the intra-abdominal length of the esophagus. Okay, we're talking about esophagus. GERD is all a pathology within the esophageal sphincter. So you have esophagus. Okay, so that should be more between 3 to 5 centimeter. Then the second important parameter is the pinching effect of the diaphragm. Third one is the angle of hiss. Fourth one is the arrangement of the mucosal folds. So if they have asked physiological mechanism, next time there are high chance of pathogens of GERD to be asked. Just a guess potential question. So you can write that here. So here what happens, the intra-esophageal sphincter pressure would go down to less than 6 mm Hg. Normally 6 to 25 mm Hg. Intra-abdominal length of esophagus becomes less than 12. This is the most important parameter. So this becomes like less than 2 centimeter, then GERD, and then after time there's a raised transient lower esophageal sphincter relaxation. Okay, so that's how the physiological mechanisms are. So finally, let's go ahead with the treatment of irritable bowel syndrome. So whenever irritable bowel syndrome comes in your mind, it should be like a confused gut. Okay, like it doesn't know what to do. It will either go to diarrhea form, or it can go to a constipation form, or both. Okay, so just telling. So that's how it is. It's a chronic thing. Chronic functional GI disorder characterized by abdominal pain and altered bowel habits. Abdominal pain and altered habits. But there's no any structural abnormality or structural pathology here. So first point is what? Dietary and lifestyle modifications. The second point with respect to pharmacological. And third is abdominal pain and blotting. So dietary lifestyle is low FODMAP. FODMAP stands for fermentable oligosaccharide, disaccharides, monosaccharides, and I think it's something like polyols or something. Polyols, if I'm not wrong. Yeah. So low FODMAP, increasing the fiber diet, avoiding caffeine, alcohol, fatty acid, regular meals and hydration. This generally you write, but remember to write this keyword, low FODMAP. That's very important to mention this. Low FODMAP. Okay. Then the lifestyle modification, regular exercise, stress management and all. Yeah. And then pharmacological management could be what? With respect to, with constipation means osmotic laxatives and pro-secretory agents. At least remember one each. So constipation features is osmotic laxatives, and that is PEG, polyethylene glycol or lactose. Pro-secretory agents is linaclotide. If you want, you can remember. Okay, at least one I'll remember. Osmotic laxatives. Then IBS with diarrhea means give loperamide or rifaximin. Okay, or a bile acid sequestrin. Remember one for each is enough. Then abdominal pain, you give antispasmodics and TCS like amitriptyline, antispasmodic like hyoscine that relaxes the gut muscles, SSRIs. If you want a more detailed answer, if you want you want to make the fulfill the page, then you can write it all. Okay. Then yeah, this is one sec. So yeah, so with this constipation, with diarrhea, with abdominal pain. Okay, then probiotics here is what? And psychosocial probiotics, lactobacillus, and yeah, bifidobacterium. So remember the probiotics, that is one, is enough. And then CBT, you can take a snapshot here. Yeah, that's it. And if you want a mnemonic clover, you can take a snapshot here as well. And then maybe I'll just take it here this way. Yeah, that's it. Thank you so much.